A very good morning and welcome to our YouTube channel. www.painfreepartha.com is my website and my YouTube channel is Painfree Partha. And listen to all those things, subscribe and share my YouTube channels. So today's topic about oxygen dissociation curve, what to know like. So whenever I talk anything on academics about, salute to the legendary teacher of 2 centuries, Professor Ravi Shankar is currently the director of C Dreams and e-portfolio in Mahatma Gandhi Medical College and Research Institute, Pondicherry. So whenever we go for a pre-anesthetic checkup, the first investigation, what will you look for? The first investigation we look for is a hemoglobin. That is what is important for us. We look for a hemoglobin. LAVOISIER and LAPLACE in 1779, what did he say? He said, if you inhale some gases, some acid is produced. Acid is what? Carbon dioxide. You are inhaling some gases. Acid is produced. So he called it as acid producer or genesis of oxy. So oxygen. If you inhale oxygen, you are an acid producer. This is what is the reason, possible reason behind the name of oxygen. Now we go to atmospheric air. This atmospheric air contains 78% nitrogen, 21% oxygen, and the rest is argon, carbon dioxide, traces of helium, neon, and krypton. So what is the majority? Nitrogen, 78%, and oxygen is 21%. Now, what is a normal barometric pressure? 760 millimeters. Now, if you want to know the partial pressure of oxygen, we know it is 21% of atmospheric oxygen is atmosphere is oxygen. So, atmospheric pressure is 760. Now, if you want to know the partial pressure, it is 21 by 100 into 760. That is 160 millimeters of mercury. It gets humidified in the airways. If it goes, it adds water vapor. That is what is called humidification. It becomes around 150 now. 160 becomes the partial pressure 150. Now it goes into the alveolus, the carbon dioxide dilutes, and if we go into the arterial, the PaO2 is 95, capillary is around 30, and the mitochondrial is around 10. And if it is less than 2, anaerobic metabolism starts. That is what is called the Pasteur point. So at a mitochondrial pH of 2, anaerobic metabolism starts. This is how this epithelium, basement membrane, endothelium, RBC, capillary, the alveolus. This is the alveolus, tight junctions and loose junctions. The oxygen comes inside. Now alveolus into the plasma as dissolved oxygen. Then it goes and gets transferred to the hemoglobin to become the PaO2. Now this is what is called the oxygen cascade. It will come 160, 150, 105, 95 to 100, slowly 75 with the venous, 40, all these things becomes the oxygen cascade. This is about the decrease in the partial pressure of oxygen from atmosphere to mitochondria. This is what is called oxygen cascade. The decrease or the decline in the partial pressure of oxygen from the atmosphere to the mitochondria is what is called the oxygen cascade. Now again I am telling you, this is the dry atmospheric air, 160 millimeters of mercury, humidified, end expiratory gas, alveolar gas, arterial blood, mean capillary is around 40, cytoplasm, mitochondria. This is what is called as the oxygen cascade. Oxygen is carried in two forms. Dissolved is 0.3 ml per 100 ml. It is very less. Dissolved oxygen is very less, but it is important because it determines the PaO2. It transfers oxygen to hemoglobin, and it is the small quantity which diffuses to the tissues first. This is about 0.3 ml per 100 ml. Now you have 1 gram of hemoglobin carries. Hemoglobin is the main oxygen carrier. How does hemoglobin oxygen is carried? Means it's through hemoglobin. Now 1 gram of hemoglobin carries 1.34 ml of oxygen. This is Hoffner's constant is 1.39. Actually, it is only 1.34. Now you have the hemoglobin of around 15. 1.34 is how much? It is around 19.7 ml plus 0.3 ml as dissolved oxygen. So you get 20 ml per 100 ml. I am going back again. We have already told dissolved oxygen is 0.3 ml. Okay. Now 1 gram of hemoglobin carries 1.34 ml of oxygen. We have how much hemoglobin? 15 gram hemoglobin as an average. You take it like that. So it carries around 19.7 ml. So 19.7 plus 0.3 as dissolved oxygen, we carry 20 ml of oxygen. This is around 200 ml per liter or 1 liter per 5 liters. This is what is the normal oxygen content. How much it is? 1 liter plus for 5 liters. 1 liter, 250 ml is consumed, 750 ml returns. So the saturation Venus is 75%. Now we will go to this again. What is known as the oxygen flux? What is coming out? Cardiac output into 1.34 into hemoglobin into saturation. This is what is called the oxygen flux. Think here, the saturation is very important. That is where the oxygen dissociation curve matters. Oxygen flux, oxygen saturation is very critical. Now I will go again when I see the oxygen dissociation curve again. Now we go hemoglobin plus is equal to heme plus globin. 4 heme molecule plus 4 chains of hemoglobin, 2 alpha and 2 beta chains, 4 hemes ferro proto porphyrins can attach 4 oxygen molecules. Ferrous becomes ferric. Oxygenated hemoglobin. This is what is the basic underlying physiology of heme and oxygen combination. This is protoporphyrin. Now, what is cooperative effect? Oxygen entry to hemoglobin promotes further oxygen entry by increasing the affinity 500 times to suck more oxygen. This is what is called positive cooperative effect. When it downloads in tissues, the reverse happens. So the affinity decreases, oxygen goes down. Now, what is it? In the hemoglobin, 4 oxygen is there. Now, 1 oxygen gets attached to the hemoglobin. The affinity increases. Tuck, tuck, tuck. All the other 3 comes. This is what is called positive cooperative effect. 1 goes out to the tissues. Tuck, tuck, tuck. 3 go out. This is what is called the negative cooperative effect. This is what is called the parents and the parent effect. Sometimes 1 starts to go, all the 3 will go. 1 starts to sit, all the 3 will sit. Cooperative effect is the reason behind the curve to be, what is the curve? I will come back again. Oxygen dissociation curve to be sigmoid. R form is relaxed, oxygenated. T form is deoxygenated. T D. Remember like that. Taut form is deoxygenated. Now this is the T form is deoxygenated and R form is oxygenated. Now again, I'm telling you, this is here you see oxy is coming like this. Oxygen is getting attached. Deoxy means it's throwing out. This is alpha chain, alpha 2, beta 1, beta 2, hemoglobin and heme and oxygen combination here. 4 are getting attached in oxy and deoxy. Now, what is oxygen dissociation curve? Hill's equation is about any equation of a variable which has got which determines the sigmoid shape. That is about physics. We'll leave it. PaO2 versus SpO2. This is what is the oxygen. Now we have ODC means what? It is a curve which x-axis as partial pressure and y-axis as saturation. I will repeat again. Oxygen dissociation curve is a curve drawn with X-axis as partial pressure of oxygen and Y-axis as the saturation of oxygen. Curve to PaO2 to SaO2. 27 means it is 50%. 40 means 75 venous. 60 is 90. 100 is 98. This is how we should draw the curve. We cannot just like that draw. 27 is 50%. That is what is called the P50. P50 means it is 27 millimeters of mercury. When you say shift to the right, it means just that the curve is not shifted like this. The P50 should be 28. When you say the curve is shifted to the left, P50 should be 26. This is how we see the curve to the right or left, not with whatever drawings we see that. 40 is venous. So you draw the curve 25, 50. 25 here, 50 there. Purge. Then 40, 75, drop. 60, 90, drop. And 198. The curve you draw, then it will become the oxygen dissociation curve. You can see here around 27, P50. Again venous, 40, 75. Again arterial, around 198. This is how the curve is like this, sigmoid shape. At around 60 millimeters of mercury, it is 90% saturated. Again, I am telling you, at even 60 millimeters of mercury, it is 90% saturated because we need saturation for the oxygen flux. Cardiac output into 1.34 into hemoglobin into oxygen saturation is oxygen flux. How much oxygen is thrown away from the heart? There it is determined by saturation. We get 90% saturation with only 60 millimeters of mercury. We can see the content here. Now here 1000 ml, already is 800 ml. So in between this 1000 ml venous 250, that is we have already seen. Now I have told shift to the right and shift to the left. It is very difficult to remember because increased temperature, increased DPG, increased PCO2, all these things will shift to the right. pH decreased. How to remember this? So I do remember like this. Increased PCO2, increased hydrogen ions, increased DPG, increased temperature. All these things will shift to the right. What are the things? Increased hydrogen ions, increased PCO2, increased 2,3-DPG, and increased temperature. The reverse. Decreased hydrogen ions, decreased DPG, decreased temperature will all shift to the left. So this 27 P50 will become 25 or 26. Shift to the right. This is what is important. Less. Now I will again tell you. This is little easy but little difficult. Your curve is shifted to the right. Means it has got less affinity to oxygen. Oxygen affinity is less, so offloading is more. That is what do we mean by shift to the right. Affinity is less, offloading is more. If you have a curve to the left, then affinity is more, offloading is less. If the oxygen and hemoglobin is affinity is more, then it cannot release the oxygen, so offloading is less. That is what is shift to the left and shift to the right. Right means oxygen offload, affinity less. Left means affinity more, offloading less. Again, I'm telling these are the factors which shift to the right and which shift to the left. Hemoglobin oxygen binding curve. Steep is systemic and plateau is pulmonary. Now what is called Bohr effect? Increased PCO2 and acidosis can cause right shift. Hydrogen ions bind to globin chains to effect a conformational change in heme attachment, favoring unloading of oxygen we want to happen in tissues. So in tissues, there is an acidic environment. As soon as it goes there, this acidosis causes shift to the right so that oxygen is offloaded. That is what we want in the tissues. Oxygen to go from the blood to the tissues. So this is what a basic acidic environment rather than an extravascular environment. of the tissues, basically cellular tissue is slightly on the acidic. So this causes a shift to the right. So that causes oxygen offloading. What is Haldane effect? We have told acidosis shift to the right. Now deoxygenated blood can pick up more CO2 is Haldane effect. Now in the tissues, oxygen acidosis is there. The Bohr effect is working. Oxygen is offloaded. Oxygen offload means it is deoxygenated hemoglobin. This deoxygenated hemoglobin can easily pick up carbon dioxide rather than oxygenated hemoglobin. This is what is called the Haldane effect. Think of tissues. This is God's graciousness. In the tissues, acidosis, unloading oxygen, deoxygenated blood picks up more CO2 and comes back to the lungs. So Bohr effect and Haldane effect is what is very simple terms like this. Blood flows to the tissues, curve to the right, offload, rightward shift. Blood flows through the lungs, environment affinity is higher, leftward shift. From the lungs, the blood sucks oxygen because affinity is more. Then what is Kennedy effect? 15 days old blood can cause decreased 2,3 dpg, shift to the left, less unloading, more affinity. This is Kennedy effect. 24 to 48 hours to become normal. So sometimes blood is stored, and if you give it, the offloading may not be there. Only the volume is there, RBC is there. The actual oxygen offload may not come in the fresh transfused blood, which is old enough by 50 days. Shift to the right in the deoxygenated capable DD, that's what I told, forms in the center of the molecule, can occupy stabilizing the T state. So that is what is the 2,3 dpg shift to the right. COPD, cyanotic heart disease, severe anemias. Sometimes if we go uphill to Ooty and stay there for some time, and it's not acute, chronic hill station occupancy. So this will cause an increase in 2,3 dpg so that your offloading is better. What is postal stamp theory? Now, this is my stamp actually, released by the government of India. Now, if you the first stamp, if you know, it is very difficult. And the last stamp sat comes out. This is what is the basic example of offloading of oxygen once it starts. Negative cooperative effect is also called postal stamp theory. Now this is all about hemoglobin. Okay, deoxygenated blood picks up more carbon dioxide is Haldane effect. Acidosis puts it to the right is Bohr effect. Kennedy effect we know 2,3 dpg. All these are about normal hemoglobins, because we want, already I told, 60% PO2, 90% oxygen flux, again saturation. These all things you should put into the mind. Fetal hemoglobin is like this, and it is shifted to the left here. Fetal hemoglobin, because it cannot offload everything, and there is no use. It has to pluck. Affinity has to be more. Higher affinity in fetal hemoglobin. Transfer of acids from the fetal to intravillous phases. Maternal HB more acidic. So that is they called as double Bohr effect, because in the maternal transfer of acid from fetal blood to maternal intravillous space, maternal HB is slightly acidic. Maternal HB is slightly acidic. What did we tell? Acidic means offloading. So it will offload. Fetal HB is slightly less acidic. So it will pick up. So fetal HB will pick up, maternal HB will release. This is what is called as the double Bohr effect. We go to myoglobin. So many races are there: human fetal, human maternal hemoglobin, human fetal. See here, there is no sigmoid shape at all. Offload, onload, nothing will come. So myoglobin has got no cooperative effect, hyperbolic curve. Yes, it is a storage specialist, and adult hemoglobin is a transport specialist. Hemoglobin and myoglobin is oxygen transport protein, binds with 4 oxygen, it binds with 1 oxygen. Oxygenated at lungs, oxygenated at muscle cell cytosol. HbO2 unloads into the tissues when PO2 is 40 millimeters. P50 is 27, P50 is only 2. ODC is sigmoid and ODC is hyperbolic like this. Already I have told oxygen flux is cardiac output. So in a perioperative or a critical care setting, maximize the cardiac output, maximize the hemoglobin and maximize the saturation to get the best of your oxygen flux. What is SpO2 and what is SiO2? Pulse oximeter, ABG analysis and variations. Now we have 53-year-old male presented with cyanosis. SpO2 is 88, but if you prick and take an ABG, it is 100 and SaO2 is 99. So that means this is what is called a saturation gap which comes in with hemoglobinemia. Hemoglobin is altered. Oxygen saturation gap is the difference between calculated oxygen saturation from a standard blood gas machine and the reading from a pulse oximeter. Put a pulse oximeter, you get a reading of 88, but if you take an ABG and see it is 98. This is what is called oxygen saturation gap. If it is greater than 5%, the patient's hemoglobin is abnormal. It may be methemoglobinemia, self-hemoglobinemia, or a carbon monoxide poisoning which shifts like this. See, we should understand what is oxygen saturation. Ectopic pregnancy we have got. Pulse is 140 per minute. BP is patient is pale, very bad. What will be the saturation? Oxygen saturation will be 100% only. Doesn't correlate with shock or whatever it is. How much hemoglobin, percentage of hemoglobin is with oxygen is what is saturation. So it doesn't mean when the BP is 90 or the BP is 170 or something like that. So chronic anemia sometimes shift to the right. Slippery slope or a life-saving escalator. Now, what is this? This slope is slippery. When you come here, tadak, it will fall here. That is what is the slippery slope. When it goes down to 60 millimeters is fine, 90. After you come to 55 PO2, it comes down like this. So it becomes a slippery slope and gets you down. But sometimes if you start oxygenating and it goes up here to 60 cell, it's a life-saving escalator. In cardiac surgeries, the leftward shift of the oxygen hemoglobin curve during hypothermia may be detrimental to oxygen therapy. So we mean sometimes good oxygen saturation, but less delivery because decreased temperature will shift to the left. So that is what is very important. Perioperative hypothermia. Get it to 36 plus. That is what will idealize your oxygen delivery than your saturation. Leftward shift in log shock, hypophosphatemia, acidosis, transfusion of DPG deficient were avoided. So no such change occurred. Now what is aging? Aging patient, rightward shift. Aging blood cells, leftward shift. Carbon monoxide poison, already I have told you, the shift to the curve. That is what is happening in when you see the saturation gap. Red cell hypophosphatemia, HbA1c has got more affinity, but compensated by increased 2,3-PE. So there may not be, there are a lot of small things, but it may not significantly affect or change P50. Stored blood loses its 2,3-DPG by 14 days. So hence transfusion of blood cells may be only volume. It may take some days to get replenished and get back again. As long as the red cell pH is normal, many hemoglobinopathies, no shift. So can we quantify the shift? We have told acidosis will shift to the right. Less acidosis, alkalosis will shift to the left. Can we quantify? Now the pH is 7.2. How much it is to the right? 7.24, 4.9 millimeters shift to the right from 27. 7.51, 3.59 millimeters of mercury from 27 back. Venous blood shifts are more. So if the pH is 7.24, 1 decrease, 4.9 millimeter decrease to the right, increase to the right. It may be 30, 31. No, P50 values are significantly higher in the females, 28 sometimes, and less sometimes 26. a lower oxygen affinity of hemoglobin in females. So we have discussed oxygen, we have discussed a cascade, we have discussed a sigmoid curve like this, and the cooperative effect. What is the left causing physiology, right causing physiology? What is Bohr effect? Acidosis shifting to the right. What is Haldane effect? Deoxygenated blood can pick up more carbon dioxide, and this is the clinical relevance of all those things. Thank you very much for the kind cooperation and listening. You subscribe to my channel Painfree Partha.